Steve Fort. He's my co-founder. I met Dr. Steve in Texas while working for a clinic, and he was one of the therapists who was working in the same clinic. We have this passion to learn and to present and to teach superior skills, clinical reasoning, evidence-based practice. I'm doctor of physical therapy, board certified orthopedic and clinical sports specialist, and fellow of American Academy of Orthopedic Manual Physical Therapists. And Dr. Steve has followed the similar route and has done similar trainings, brings in like similar skill sets. And I think we do this program so that we can pass on these skills to you, and so that you can treat complex patients in an efficient manner. Talking about Dr. Amit, Dr. Amit has been with us for a long time. I think I met Dr. Amit a couple of years ago, and he definitely stood out of all our fellows. His passion to learn. He's been a PT for a long time. I think you have more than 10 years of experience.
15 years.
Done like
15 years, sir. More
15
than
years of experience. Yeah. So he's been practicing for a long time. He owns his own practice in West Bengal. And he's done a bunch of certifications, and I could see the drive in him to learn, because if you've been practicing for greater than 10 years and you still come to courses and you're still passionate about the profession and you're still keen to learn, I mean, that says something. So I think...
I'd like to mention something here, like just my clinical valuation and interpretation about the case studies, about the presentation of the patient has gone way up from last 2 years. The satisfaction for myself and for the patients is amazing. After joining Gen Physio, specifically if I say after joining Dr. Tejinder Singh and Dr. Stephen Ford, my thought of approach has been upgraded a lot. It's been amazing. This 2 years being amazing journey for all of us. It seems to be the whole bunch of people who were practicing under Dr. TJ sir and Dr. Steve is awesome actually. Yes, sir, please.
Yeah, so I mean, so the idea was to bring this, train more people so that people can teach. I mean, I think we're trying to build a team in India where people like Dr. Amit, who have been practicing for a long time and who have developed the skill set, spending time with us. I think we come to India twice a year now. And I think I've met Dr. Amit at least 3 times. Yes. Or me and Dr. Steve has met Amit 3 times rather. Yes. And we've spent enough time that we feel confident that Dr. Amit can teach. And I think Dr. Amit has that very complex and intricate understanding of the issues. I think that's where we're coming from. So over to you, Dr. Amit. I think this is a very, very complex but very interesting lecture. And the clinical situations Dr. Amit talks about, all of us have encountered in the clinic, because this is such a common patient presentation. But not all of us have the understanding of how to encounter or how to approach it. So over to you, Dr. Amit. And yeah, I mean,
thank you, sir.
Teach us something. Thank you.
Hello, everyone. I'm Dr. Amit Barnwal, practicing at Raleigh for more or less more than 15 years around. I've been joined with TJ sir and Dr. Steve from last 2 years, and the clinical practice level of us has been great. It has been raised really very new heights. The satisfaction is great. So again, we are here with another interesting topic like sciatica. It's the very most common findings we usually see daily in day-to-day life in our clinical practice. The patient used to come like sciatica. Is the disc only the culprit? So we are going to reveal the myths about the latest research and the evidence about the sciatica and the disc. So what are the contents we are having? We'll have a detailed knowledge about the sciatic nerve, its epidemiology and the differential diagnosis. This we'll talk about sciatica, how it's related to different associated structures, special tests, research articles, some case studies, and treatment and some exercises. So sciatic nerve. We know that this is a very important component of the lumbosacral plexus. It's found basically at the lumbar and the sacral junction. It comes out from the pelvis and enters the gluteal region via the greater sciatic notch or greater sciatic foramen. Mainly it travels from the gluteal region to the back of the thigh and all up to the way like to the heel and the whole sole of the foot. It is the largest and the widest nerve of the human body, and it is formed by the union of the 5 nerve roots. Basically, it's like L4, L5, S1, S2, and S3. So what is the importance about sciatica nerve? It's generally originates from the anterior rami of the L4, L5 and upper sacral plexus of S1, S2, and S3. It's become special because it comprises of ventral and dorsal division of the lumbosacral plexus, spinal nerves. It gives a consider is basically considered as a mixed functional nerve because it is responsible for both sensory and motor neuron functions. It's very interesting that it allows us to muscle to move, and also it helps us to feel the sensation along with the nerve. No surprise, it can lead to intense pain, and definitely it can also give a loss of ability of the movement when it is compromised either way of. So there are basically we find out like types of sciatica is 4 types like acute sciatica, chronic, bilateral, and alternative. What is acute sciatica? It is a sudden irritation of the nerves which can give you a pinching, compression, or a combination of both. It may be like burning, shooting. We generally get it around like lower back, buttocks, and the legs. It comprises of this in the hip region also we can get some pain. It's very difficult for the patient while sitting and standing or from sitting to standing. The pain may last from 1 to 2 weeks generally. But in the chronic sciatica, it may be the pain is long lasting like from months to years, or it can be intermittently or it can be a diffuse sort of a pain. What are the conditions we generally get worsened about sciatica? Like it may be inflammatory injuries, infections, and most importantly, it may be spinal or pelvic misalignment issues. So this is the area where we are looking at. This is the area where most of the patients are being underdiagnosed or are not properly getting a proper management at this region's involvement. So how this is basically involved? Because basically the patients are mainly gets a temporary relief with some medications and all, but I'm sorry. But yes, this region can play a vital role. The spinal, lower part of the spinal region and the pelvic misalignment. What is the other one? Like bilateral sciatica is very rare though. The sciatica can have affect the both the legs. It may be due to the multiple herniated disc or the disc degeneration. It can feel in both the legs at the buttocks region also at the same time. Maybe one leg gets some more pain or the other legs, it may vary. There is an alternative sciatica as well, though these are very rare, not considered so much. We usually don't see this sort of findings generally. So what are the motor attachments of the sciatic nerve? Basically, it innervates the posterior thigh like biciferous, semimembranous, semitendinous. It also get attachment supplied to the hamstring portion of the adductus magnus. The remaining part is basically supplied by the obturator nerve.
Dr. Amit, sorry to bug you. Can you be a little bit louder, or you can increase the volume? I don't know how you can make it happen. Yeah.
What are the basically two branches, terminal branches of the sciatic nerve? Basically it divides into tibial nerve and the common peroneal nerve. The tibial nerve basically supplies at the posterior leg and some part of the intersecting muscles of the foot, whereas the common peroneal nerve supplies the anterior lateral leg and the remaining intersecting muscles of the foot. Basically supplies the posterior aspect of the whole lower limb, like posterior thigh, entire leg, and the entire foot. What are the sensory distribution? Like it gets basically supplied to the, not getting a direct supply to the thigh region, but it gets supplies with the terminal branches, like the tibial nerve and the common peroneal nerve. It generally supplies the skin of the posterior lateral nerve, lateral foot, and the sole of the foot by the tibial nerve, and it supplies the skin of the lateral leg and the dorsum of the foot by the common peroneal nerve, which also known as like femoral nerve. There is also a sural nerve which is been coming out from the S1, S2, but it generally acts as a cutaneous nerve, providing only sensation to the posterolateral aspect of the distal third of the leg and the lateral aspect of the foot, heel, and the ankle.
Dr. Amit, can you look at the chat box? one time. Sorry, I didn't want mean to disturb
Okay,
you.
just a moment, sir.
I think people are saying that the audio is not clear. Can you use like a, a microphone or something where they can hear you better? I don't know.
I'm just trying, sir.
Yeah, okay, no, no worries. Just take your time.
What is the epidemiology? Like now, is this clear? Please let me know in the chat box. Uh, so there is a lifetime incidence reported between 10% to the 40% with no gender predominance. The annual incidence being like 1 to 5% only. There may be no association with the body height, but along with the age group, like 50 to 60 years is basically more affected rather than the other age groups. It really occurs before 20 years unless there is anything secondary to the trauma. Occupational discussion is like machine operators, truck drivers, job like white collar jobs. People are getting more affected because of just due to the physical awkward positions they are maintaining for the whole long duration. So it is a bit better right now.
Can you guys comment on the voice quality now? I think Dr. Amit has made some changes. Thank you. Can you guys hear better?
Sir, actually it is same. Sir, Amit sir, please check whether your speaker or microphone is not getting covered by anything or not.
No, it's okay. I don't know.
This is better. Some people are
Fine with
saying
me
better.
right now. Is it good?
And I think you can go a little slow. That's what
Okay,
people are
sir.
calling.
Okay, fine.
Take your time. I mean, we're not in a
So,
hurry.
so what are the differential diagnoses like herniated lumbosacral disc, lumbar dysfunctions, SI dysfunctions, spondylolisthesis, osteoarthritis, pregnancies, muscle spasm, epidural abscess, epidural hematoma, tumor, and cyst, clonus mutalis syndrome. These are the differential diagnoses of sciatica. So what we are going to cover today is like herniated disc, lumbar dysfunctions, SI dysfunctions. So let's just talk about lumbar disc. So as you can see in the image, there is a jelly-like substance in between the vertebral body. The outer part is being known as like annulus fibrosus, and the inner part is being known as the nucleus pulposus. There is, you can see that in the center we have a spinal cord, and along with the foramen, there travels the nerve root. So here we are having a small video. Let's see how this disc works on to have some more knowledge about the disc. So the outer lining is called the annulus, and the inner part is called as nucleus, which is a soft gel-like center. Outer one is like thinner layer. The function is like with shock absorbing, as we can see during the compression. It allows the vertebra to move in all directions, which is incompressible jelly-like function. The condition of the normal lumbar this is isthmus. So mostly what we get, like there is avascular or only the outer annulus is only vascularized. These basically comprise of collagen second fiber, and the rupture, it generally have a healing time of 300 days. So we can say that the 300 days is like more or less like 1 year. So we generally cannot treat these issues in a short time period. It takes some more time, like 300 days.
Dr. Amit, can you go back to etiology? I think that's what people are requesting. Okay, this is and this will be shared on the YouTube. So we're gonna have this lecture uploaded on the YouTube. Yeah. So,
Actually, my system is some bit of hanging, so I'm facing some problem right now.
no, I think you're doing fine, Amit. I mean, yeah.
Okay.
If you have any questions, guys, regarding etiology, please share on the chat. Okay.
This is good. So
So healing time is 1 year, and sometimes you have to, if it's a true annulus fibrosis tear, you have to educate your patients that it would take long time to heal, and sometimes you have to treat them or at least have a follow-up for a long time.
Okay. So what are the causing factors of sciatica and the etiology? Like repeated use of injury from sports and exercise. There may be a trigger point of the fascia. There may be excessive sitting or long driving that puts pressure on the lumbar region. There may be definitely overweight and obese patient also suffers the same symptoms. Sedentary lifestyle is one of the most common cause nowadays we are facing. Maybe pregnancy is also one of them. Spinal stenosis we come across, like spinal pathway nerve narrows are getting pathways are getting narrowed. Diabetes is one more like common factor nowadays for the neuro involvement, and there may be definitely a degenerative disc issues as well. So how this herniated disc gets involved? Spinal disc plays a crucial role in the lower back. It acts as like a soft absorber and allows a wide range of motion in all directions. If it gets herniated, what are the factors? What are the reasons, or what are the effects we get? Aggravating a nerve, triggering back pain, possibly pain and nerve symptoms down the leg. These are the common factors we get when there is a herniation disc in the lumbar region. What are the different zones of herniation? It may be central, it may be subarticular, it may be foraminal, or it may be extraforaminal. Which, as you can see in the image, like in the central is the central part where the spinal cord is being affected, or we get entrapped. There may be just alongside subarticular zone, this area, and there may be a foraminal where the nerve roots are passing. It may be there also. We get an extraforaminal zone, like apart from the foramen, or the extra part or beyond the foramen of the spine. What is the basically difference between the herniated disc and the bulging disc? The herniated disc is like where the soft tissue comes out of the annulus fibers. It spouts out from there and have an impact or compression over the spinal cord. This extrudes into the spinal canal, foramen, either of the disc or in multiple places. We call it as a multifocal extruded disc. The final stage of degeneration is like more common in the lumbar region, also known as disc exclusion, slip disc, or rupture disc is being known also. What is the disc bulge? It is also called as disc prolapse. So here the disc is just protruding out, but it is not coming out of the annulus fibers. However, because the disc protrudes into the spinal cord, it can also have some compression over the nerve roots. So just we'll see the difference between the herniated disc and the disc bulge. As you can see, this is the disc, this is the nucleus purposus, and outer layer is the annulus fibers. As you can see here, just a moment. Here the disc, just a moment. This is a plate. I'm playing it again. Here the disc is getting bulged out, but the annulus fibers is not being tearing up. There is no rupture of the annulus fibers. Just the disc is protruding out. We call it like disc bulge. It is also compressing the nerve, but in this case, what is happening? The nucleus purposus is coming out just due to the tear in the annulus fibers, where this situation is getting more involvement of the nerve areas around the disc, around the fundamental canal, and in beyond that also. Just we can have one more play. Is it fine with everyone? Should I repeat this one again?
Is this clear, guys, or do you want to see this again? So in bulging, you have the integrity of annulus fibrosis is intact. Okay.
Just I'm playing it one
Show
more.
it one more time, Dr. Amit. I think this is a great video. Can show it one more time. So see how the bulging is happening, and then see how this is a bulge. You can see the outer covering is intact, or outer layer is intact.
And
And
here
now
the
you have, yeah. Yeah. This is a good video, Dr. Amit. Yeah, very good.
so how are lumbar herniated disc causes sciatica? There is an article on 2020 that the medical term of sciatica is being said as like lumbar radiculopathy, a condition where the spinal nerves are being compressed or compromised in the lower back region, where the nerve is getting irritated or compressed, sending pain and neurological symptoms down the leg. So it was said to be like most common cause of sciatica in lumbar herniated disc. But is it so? After 2020, there was much more articles and much more research coming out nowadays, where we find that not only just lumbar herniated disc is being responsible, the associated structure around the lumbar region, around the sacral region, and in the whole pelvic girdle region, there are many more comprising situations like that can produce symptoms of sciatica like. So we'll have more research along the presentation. We'll come across more presentation along. So what are the symptoms of herniated disc in the lumbar region? Anywhere along the nerve pathway, the nerve can create pain or we have a symptom, especially like follow the path like from lower back to the buttock region and back of the thigh and the calf region. The pain may vary from mild to mild aching pain to sharp pain or even burning pain as well. It may be a joint or like electric shock pain as well. It gets worsened when we are coughing or sneezing. We can assume like in Valsalva, where the pain is more increasing if you are coughing and sneezing and sitting in for a long duration time as well. Usually sciatica affects one side of the body, but we also find bilateral symptoms can be there with the patients. Some people also have numbness, tingling, and muscle weakness in the legs and the foot. One part of the leg can be very painful, and other part can be like other legs can be very feel like numbness only. So we are having one article here like lumbar disc herniation, how the individual nerves is getting compromised and what are the symptoms we are getting with each and every nerve in the lumbar region. We just find it out. Though the upper lumbar regions or nerve involvements are not common, generally we find it out like L3, L4, L4, L5 or L5, S1. So what are the symptoms of L2, L3? Like we have pain, numbness, tingling, burning sensation in front of the thigh and inner aspect of the lower leg. Weakness we can find in iliopsoas muscles. It finds difficult with the walking or climbing up the stairs. It worsens with sneezing, coughing, or leg strengthening. For L4, we'll find like for L4, the nerve exists from the L4, L5 foramina. We generally find there is a decrease in the lateral reflex. Back pain that can radiate into the anterior thigh and medial aspect of the leg. There may be a sensory log in the same distribution. Weakness in hip flexion, adduction, weakness in knee extension is very common with L4 region involvement.
Guys, remember L4, L5 is more common. So yes, upper lumbar, we're talking about it, but L4, L5 being more common.
So what are the findings of L5 involvement? Basically, the pain radiates from the buttock, lateral thigh, lateral calf, dorsum of the foot, and even to the great toe. There may be a sensory loss in between the first or the big toe and the second toe, and the dorsum of the foot and the lateral calf. Weakness we find in the hip abduction, knee flexion, foot dorsiflexion, big toe dorsiflexion, foot inversion and inversion. This is the most common finding of the L5 in the lower leg part, along with the foot. There may be a weakness in the foot, like challenging to walk on the heels. Then generally, for the pain, we ask the patient to walk on their toes. They find it very difficult to get onto their toes. So what are the reflexes? So there may be a loss of semi-tendinosus and semi-membranosus reflex due to this L5 involvement. What are the chronic findings of L5 radiculopathy? There may be atrophy of the extensor digitorum brevis and the tibialis anterior of the leg. These are the most common findings for the chronic L5 involvement. What are the findings of S1 involvement? The Achilles reflex gets diminished, pain in the sacral and the buttock region that radiates into the posterolateral thigh, calf, and plantar and lateral foot or the perineum area as well. There may be a sensory loss, definitely in the calf, lateral, or plantar aspects of the foot. Weakness for the hip extension, flexion of the knee, plantar flexion of the toe, great toe with the foot. There may be a walking difficulty with the great toes. It can cause urinary and facial incontinence as well as the sexual dysfunction. These are the very common findings with the NS1. So we are finding so lot of involvement as because we see that it is comprising of the lower lumbar and the upper sacral region. So we are having lot of effect or lot of symptoms along the whole leg. So what are the findings of, S2, S3?
Sorry, I mean, Dr. Amit. Guys, please don't draw on the screen. I think, please respect Dr. Amit's work and please don't draw on the screen. Yeah.
So S2, S3, we have a sacral or buttock pain resulting in the posterior aspect of the leg or the perineum. There may be a sensory deficit on the medial buttock, peroneal and the peroneal regions. There are anal regions as well. It provides both parasympathetic and the motor innervations to the muscles of the pelvic cavity and pelvic floor as well. There may be absence of bulbocarbonorous and ankle ring reflex as well. So, is piriformis syndrome is related to sciatica? It is the right term. So there was a research by Beton and Assen in 1937. This is being reformed like deep gluteal pain syndrome. Basically, this is a non-discogenic cause of the sciatica that comprises of sciatic nerve involvement around the piriformis muscle. The other structures which get involved with this piriformis is obturator internus and inferior gemmelli as well, because this all together act as an external rotation of the hip.
Guys, just to give you, I think, sorry, Dr. Amit.
Yeah, so
So I think Dr. Prashant did a great lecture on how piriformis syndrome is not a right term. It is called deep gluteal pain syndrome. I'm going to share the link of that lecture. I mean, if you did not attend that lecture, you can go back. So the piriformis syndrome has been transformed into, or maybe the correct term is deep gluteal pain syndrome. Thank you, Dr. Amit.
okay. The patient typically have pain like buttock pain, worse pain with sitting. They usually have a normal findings and negative SLR test, because when we are doing a SLR test, there is no involvement from the lumbar region, so it is negative. There are few more tests like clear test, Pelvic sign, pace sign, and direct palpation of the piriformis muscle. As we said that we are having a 1 hour lecture by Dr. Prashant, so definitely you can visit there and have a more detail about non-linear. Can refer to. So there was a classification done by Weston and Assen. It was divided in the three types, that how this sciatic nerve is being involved or associated with the pathway from piriformis. So we can see that there are 6 pathways. So just we can do a small exercise here, though we have done it before, but still for the refreshing or for the revising, we are doing it again. So can anybody just tell me that among these 6 classifications, which are the most probable chances that piriformis can impact or can give a effect or compress the sciatic nerve? Like in the first image, the nerve is coming just from ventral aspect. In the second one is coming that one part of the sciatic nerve, like the common peroneal nerve division is coming in between from the piriformis muscle. And in the third type, like both the division of common peroneal nerve and the tibial nerve is coming alongside, from one is ventral and one in dorsal. In the fourth one, the whole sciatic nerve is coming in between from the piriformis muscle. And in the fifth one is like the common peroneal is coming from the dorsal aspect, but the tibial aspect is coming in between from the piriformis muscle. And in the sixth one is like whole nerve is coming from the dorsal aspect. So can you guys just give a short, like which probable chances are having more sort of piriformis giving a symptoms of sciatica? Yes, sure. I will give the specificity and sensitivity along the presentation. Definitely, I will give it.
Guys, look at the orientation of the nerve and the muscle. And then Dr. Amit will give you the correct answer.
So the right answers is like 2, 4, and 5. Sure. So that's good. So just we are moving along. So just guys, I have to just stop sharing it. Just I will add the second presentation. Just give me a few minutes. I'll be back. So just sorry guys for the interruption. About the system is having. So here I'm having a small video about piriformis. Just let's look at this. Sir, am I audible?
You are audible. Guys, please comment.
So let's just see how this piriformis muscle is involved. As we can see here, that a large portion of piriformis is being attached to the sacrum, the ventral aspect, and just is getting inserted at the tip of the GT. So any changes in the sacrum, definitely it can impact the piriformis muscle. What is the main role of the muscle? It acts as a external rotator of the hip. As I can see that this is helping in the whole extremity to externally rotate. It gets impact with hypertrophy and atrophy as well. This is okay, guys. Just you want me to repeat this again?
I think it won't hurt to actually just have replay the video again. Guys, see, if you have any questions regarding, I mean, just ask Dr. Amit.
Just I'm playing this one more time. This is the sciatic now, which is getting just from the ventral aspect from the piriformis muscles is getting down. It's having attachment towards the ventral aspect of the sacrum and getting inserted towards the GT. It's playing a role like for external rotation of the lower extremity. It gets impact with atrophy and hypertrophy as well. It is very close to the SI joint, as you can see from here. So let's move on. So this was a test done on 2020 by Sadiq Hussain and Naganath, like hand on hip sign. This was particularly done to just identify the symptomatic side of the piriformis muscle. How it was done? It is just done like, as you can see, he was keeping the hand over here and the thumb pointing out. The point where it was pointing out, basically it was giving the pain. Just a moment, guys. Just try to put. This was the side. The thumb where is being pain, where the pain was, is being pointed out by the thumb. It was a very common sign, and this is a very highly productivity test. Its result was very, the productivity of this test was very positive, like 94%, as we can see here. The sensitivity was like 86%, and the specificity was like 75. So more of like it is very high. We can say that it's a good sensitivity test. Any test negative, so we can rule out the test. So we are again here with myths about sciatica. What are the myths generally we come across in the day-to-day life? So generally, sciatica is a condition or diagnosis. Usually we see that when many patients are coming to us, they only just try to describe sciatica because they say like they are having a disc bulge, so they are having sort of pain like getting to the butt region or in the posterior thigh or on the leg. But is it so? So it was like seen. Mostly people commonly complains like sciatica condition is a diagnosis, but it is really a symptom of a problem, indicating that something is irritating the nerve root in the lower back region. It is more important. The more important was like decipher what is causing the pressure on the nerve rather than the symptoms, because generally what happens, patients generally look after the symptoms what they are getting it, but not rather they are concerned how it is being irritated or it is being compressed. So, second myth is like all the leg pain qualifies as a sciatica. Is it so? No. Why? Because sciatic nerve generally supplies the lower posterior aspect of the thigh, but we often get symptoms from the anterior aspect or the inner thigh of the thigh, inner aspect of the thigh as well. It may be like vascular compromise, maybe like muscle strain, maybe like cellulitis, or a different nerve being irritated, like femoral nerve. So what are the two sciatica symptoms? It basically runs from the mid buttock region down the leg of the back of the leg and commonly past the knee and down through the calf region. Is sciatica a main event? Basically, most of the time patient gets control of like their complaints, like they just suddenly travel a long distance, so they got pain and it was like sciatica. Sometimes the patient comes and say like they just suddenly wanted to lift a suitcase and they got a pain. They may be. They sometimes the patient says like I'm just lifting a baby or just I'm lifting somebody or some heavy objects. I got stuck and the pain started. Is it so? We generally find that this is not the macro trauma. There may be a micro trauma like, because a repeated motion creates some symptoms, because how the patients, how nowadays the white collar patients are generally having a long sittings for long hours, and like for the drivers as well, for the bus drivers or the truck drivers, they are continually having a same movement, just sitting, turning, sitting, turning, sitting, turning all the time. So this is for a long course of time. This microtrauma also creates issues with the disc or disc rupture or the nerve pathology symptoms. So nerve maybe get irritated with the microtraumas as well. It is not necessary that only a certain movement has caused that issue. So this is the one movement. So let's move on to the next one. Am I clear with this, guys? Just 3 myths. If anybody wants to repeat, I can do that. So let's move on. You have sciatica, or you should stay in bed or rest. Generally, the rest is being prescribed generally in the most of the cases in radiating pain in the lower extremities. Is it so? There was a research done that most patients do better if they are remain active and avoid excessive rest. It is being numerous studies done along the research articles I came across, though it was very challenging for me to put up all the researches here. But I found out this, like it being, if you are in a motion or you are in a little bit active relative activities or daily routine activities, it is compared with the resting patients, we find it out that the prognosis was much more better, much more easier for the patient as well to get up more improvement and get up more healing along the days with the activities. Medication is the best way to provide relief from sciatica. So generally we have a concept like if there is a routine pain, medicine can only help. Is it so? It seems that the new articles or the research articles which are coming out nowadays, that they find that very less research or lack of evidence of efficacy of the drugs. So on long-term basis, though medicine can provide some short-term basis relief or helpful for the patient, but in long-term basis, it's the research is very lacking. It is very poor research on this. That medication can definitely give you a long-term research relief from this sciatica pain or any sort of pain. So what is another myth? Like sciatica is the only way to truly get remedy. Surgery is the only way to get remedy from this sciatica. What the fact was like resolved within the 6 weeks. If there is a sciatica, generally we get a resolution within the 6 weeks. But in very severe cases, there might be surgical or operative can be a bit affected. But generally, some sort of numbness and weakness get resolved. But in case of very severe cases, there definitely we need to go for the surgeries. But the prognosis after the surgery also is a bit challenging, and still the evidence is lacking that how much the sciatica operative cases are getting improved. Anybody wants me to repeat the myths about sciatica? Or it is clear with everyone? Okay, I'm moving forward. So there are some special tests for sciatica. Let's move along. So slump test. So this is one of the most sensitivity tests we do for sciatica. Like patients sit on the edge of the chair or a table, examiner stand aside of the patient. We generally ask the patient to have a forward head, just to ask the patient to just put down the head. Put down the head, flex the upper thoracic region like this. And we just generally actively ask the patient to lift their knee, do a knee extension. And just we ask the patient that if they are having any sort of aggravating symptoms or not. If say patient says no, then we just proceed with the ankle dorsiflexion. We ask the patient that if the symptoms are getting worse or not. If at any situation the pain gets worse, then this test is positive. So what is the implication of this test? Like definitely we can say that there is a compromise of dural lining or spinal cord or the nerve roots in the lumbar region. The second test what we generally do is FLR test. So generally we ask the patient to be in a supine line. We lift the leg. And we just ask the patient about in between that like 30 to 70 degree, which is the pain eliciting area or range for sciatic nerve to get entrapped or get involved. If the patient says that yes, they are having pain in this range like 30 to 70 degree of hip flexion, just we ask the patient if they are not having any symptoms. If it is positive, we are getting the symptoms. If it's positive, if it is not, then we ask the patient to have a dorsiflexion, or we generally do it for the dorsiflexion. Again, we ask the patient that the symptoms is there or not. We can again aggravate this or have a more impact of dural involvement. We ask the patient for more involvement. We ask the patient to do a neck flexion. So at this posture, we can see that definitely there may be if any sort of involvement with the herniated disc involvement is there, definitely it's going to be positive. Lack of pain may be a reproduction with dorsiflexion or neck flexion is indicative of a hamstring tightness or SI pathology. After this position also, if we are not getting any sort of aggravation of the symptom, everything is staying the same, then definitely we can assume that definitely the nerve is not being compromised in the lumbar region, or due to the disc bulge or disc herniation. It is being involved due to the hamstring tightness, or maybe there may be something like SI pathology or SI involvement. So as you can see, the sensitivity is like moderate 0.52, but the specificity is like 0.89. So we are having a high specificity. So any test positive, we can rule in the diagnosis.
Guys, I hope you guys know what the difference between sensitivity and specificity is.
So there is another test, which is a very good test. It is a cross SLR test. Generally, what we do, we perform the same SLR test, but we perform in the normal leg or the uninvolved side. We generally ask the patient to just have a hip flexion. If there is any sort of aggravation of symptoms at or beyond 40 degrees of hip flexion in the normal leg, and the symptoms get aggravated, then definitely we can rule in like get central disc herniation, because the specificity is like 90%, which is a gold standard reading. There is a severe case of severe nerve root irritation. There are some other tests which are not so much relevant, because the sensitivity and the specificity is not so relevant, like Beggar test, Chem test, and Yeoman test. So let's go to the lumbar somatic dysfunction. So this was the article I got, which was a bit late, like 2012, the somatic dysfunction and its association with the chronic low back pain. There was a study done on various patients, like all the patients were having a chronic low back pain. They found out that is there any dysfunction present in the lumbar region. They found out that yes, there was. Maximum number of patients were having a somatic dysfunction in the lumbar region. How they did diagnose this presence? They did it generally with like 4 art criteria. Can anybody tell me what is this 4 art criteria? Do anybody know how to find
Can
out?
anybody tell us what art is on the chat box?
Anybody? That's good. That's good.
Asymmetry.
That's for like asymmetry, range of motion, tissue texture, and the tenderness. That's good. So SI dysfunction.
Yep.
So how SI mimics the sciatica pain? The sacroiliac joint dysfunction can affect the sciatic nerve. How? Because there is a very close uh, alignment of the nerve which passes through the joint, like ventrally the L4 L5 is passing on. There is definitely superior tibial nerve, and in dorsally dorsally L5 S1 and S2 is passing. So it has any involvement with the joint, any hypermobility or hypermobility can affect the nerve, as because this is running along with the joint in the dorsal aspect and in the ventral aspect as well. So treatment for the SI joint can give more impact rather than the surgical aspect. So we can, if we restore the normal range of motion of the SI joint, definitely the symptoms can come down. We get get very good results by just restoring the SI joint. So generally, what are the common symptoms we find out when there is an involvement with the SI joint? There may be a low back pain, really one-sided, the pelvis and the buttock pain, hip and groin pain, sensory loss, there may be pain, numbness, tingling, weakness. Actually, these symptoms, what we are finding are not true symptoms or not true weakness or numbness. It is just joint related. Once we restore the joint, we have find that the symptom has gone within 2 or 3 sittings or even 4 or 5 sessions only. We have a reduced range of motion in the lower back, pelvis and the hip. There may be pain increase running while running and putting weights on the one side. It's very difficult for the patient to put weight or just have a walk or have a run. So pain stays above the knee, but it can radiate down the leg, calf, up to the calf or the foot. Feeling of the pain and the leg instability, it just look like a buckling up. It just like give away. The patient, when they stand, they are not able to put weights on their legs. It may be very severe, moderate to very severe pain. It's very fine, difficult patient while sitting in this sort of symptoms of if they are getting it. There may be a feeling of pain and leg instability. There may be a sharp and stabbing pain going from sitting to standing. We often find there may be a variety of patients like their patients are not able to sit properly, or when we ask the patient to get up, it's very fine. They just cannot get up. They just get up like this, and they cannot sit properly. They just fall off. We find patients in such situation also. They may be unable to sustain posture for longer periods. The patient finds very difficult while performing or while lying or while sitting to be in the same posture for a longer duration. They have a disturbed sitting and sleeping pattern as well. So these are the findings which are very much similar to sciatica, but these are not the sign. But basically what we find is it is not related with the any herniated disc symptoms. So I just gave it away. So how many different combinations of dysfunction can be present in SI joint? Can anybody give any guesses? Those are the new guys out there. I would like them to answer this.
Not people in the cohort.
Not
Can you please tell us how many possible permutations and combinations
can
possible with ilium, L5, sacrum, coccyx? Because all of them can impact sciatic nerves or have like symptoms mimicking sciatic nerve or symptoms down the leg for that matter. And that's why we have the program because I mean the complexity is at a different level.
Anybody would like to take some thought?
No. You have to give us a number. Like how many possible combinations? Like number. Give us a number. Like 10 possible combinations of SI dysfunctions, or all these possible lumbopelvic dysfunctions are possible. 15 are possible. I think 8 to 10. Okay. Keep going. 10. And that's why treating some of the patients are very complex, just because you have like so many different 15. Okay. I think Dr. Amit will demonstrate a video for the same, and it won't show all the dysfunctions, but I think he'll show you some.
So just we are moving on. So
10, 15. So okay.
So the number is 128. So 128 different sort of combinations of dysfunctions we can have in a SI segment or SI joint. So this is really amazing. When I came to know this, it was very surprising for me as well. So 128 possible dysfunctions can be present only in a SI joint dysfunction area. So this is really amazing. So what are the possible terms we get it or dysfunctions we get it? Like SI dysfunction, there may be a torsion, flexion, or a symmetrical torsion is like L on L, R on R, extension or backward torsion, or asymmetrical torsion, it is like L on R or R on L. There may be some unilaterals like flexion unilateral or flexion, unilateral extension of the sacrum. So these are the different sorts of dysfunctions we can find in the SI. Which we are really unaware of. So this is very challenging and interesting as well to learn and to explore. Here, this is the segment which is need to be covered nowadays by everyone with the latest evidence and latest practice.
So we guys talk about this in our pelvis module, I mean, in details, because this is an 8-hour lecture we teach, and then we do hands-on on this because the complexity at SI and L5 is ridiculous. I mean, I think we don't have the time to discuss that right now, but just to know that, I mean, you have to have the understanding to be able to treat specifically if you understand this level of complexity.
So there is a video. If we play this video, then we'll talk of. As you can see here, there is a nutation of sacrum and a counter nutation of sacrum on the opposite side. What is nutation? I will just try to demonstrate this, and again I will play the video. Okay, just let's play the video first, and we'll demonstrate again. I'm playing this one more. As you can see here, when there is a counter nutation of the sacrum on the one side, there is a nutation on one side and counter nutation on the other side. So what is basically happening? This is coming anteriorly and this is going posteriorly. As you can see, along with this, there is a change in the pubic bone itself, and the alignment of the innominate is also changing in bilateral side. So how does it look? Just I'll try to demonstrate this.
Can all this impact your sciatic nerve? Absolutely.
Yeah,
So
definitely. Definitely it has a great impact over the sciatic nerve. So this is the sacrum. This is the posterior aspect from your side. I'm just skipping it just to make you understand. And this is the innominate bone. So if there is any sort of movement, definitely it can impact the sciatic nerve because two nerves are coming from the lumbar region and three nerves of the sciatic nerve is coming from the sacrum, S1, S2, and S3. So any change in the alignment of the sacrum can have a great impact over the sciatic nerve. There may be a strain or it gets insufficient effect. There may be, along with this change, there obviously we have an impact over the innominate bone as well. Just when this moves, along this also moves. I hope it is visible.
yep.
So when there is a change, like when there is a counter nutation of one side, there is a counter nutation on the opposite side. And along with this, the innominate bone also gets misaligned or disaligned. I hope that makes it clear. Now move on. There is one more dysfunction. I'll just try to explain this.
Guys, this is very subtle, so please pay attention. Okay, Doctor.
Very subtle because we are having only 2 degrees of filament of movement. So the movement is very subtle and it's very challenging to find it out how much or what dysfunction is there. Just see this. This is called inflare when the innominate bone is getting moving front, and this is the outflare when the innominate is getting moving posteriorly. How does it look like? So this is the exterior part, posterior part from your side. So what is, sorry, I'm just keeping this. So this is the ventral part or the anterior aspect from your side. What is the inferior? What is inferior? It moves in. And what is outflare? It moves out or posteriorly. The innominate bone moves out. This is called outflare and this is called inflare. Outflare and inflare. This is okay, guys? Just playing this video one more time to have a better understanding. Inflare is moving in and this is outflare, this is moving out. So what are the tests for the SI joint? There is a test for SI. We used to do that, we call it like cluster of Laflette. As we can see, there is a gapping test where we are just having putting both the hands over the ASIS on both the sides and we are just trying to gapping it. If there is any sort of issues are present in the SI joint, we can get some symptoms. Then we can say that yes, this test is sensitive. There is another test. It's like compression test, where the patient is lying in a sideline and we are keeping in the hand on the GT and we are just trying to push it down. Another test is like thigh thrust. Patient is supine lying. We have a 90-degree of hip flexion and full flexion of knee and we just try to push it down. We can expect some sort of symptoms in the SI joint. There is a Glaston test, where the patient is lying at the edge of the bed and one leg is being full flexed with the hip flex and knee flex and another leg is being hanging, like we're trying to make it like an extension. If there is any issues with the SI, definitely there are symptoms, we can find it out. What is the sacral thrust? Like the patient in prone lying, we are simply just keeping the hands over the sacrum and we are just trying to push it down. If any hypermobility or any issues is present with the SI, definitely we can get some symptoms. As we can see that the sensitivity is like 91% and the specificity is like 78. So it is more of like more sensitivity is there. So any test is negative, we can rule out the test. But definitely, if any 3 or more tests are positive out of 5, we can say that definitely SI is involved. But this test does not specify the dysfunction, what sort of a dysfunction the SI is having. But definitely, we can say that there is some dysfunction, but not the type of dysfunction which is present. So for that, we have to do some of the more tests. So we'll move on with some latest research articles. So what are the prognosis of disc herniation? This is a very latest article that you can see like from 2023. So what was the prognosis? Like the study varies on the outcomes of the herniated disc prognosis, but the majority of cases responds to conservative management. So there are 30% of the people who complain of back pain at any point of 1 year. They generally get treated or they get relief generally without any sort of conservative management at home only. It should be mentioned that many cases of disc herniations are asymptomatic and found that inadvertently on advanced imaging. Of symptomatic cases, like 90% of them resolve at 6 weeks following the injury. Surgery may lead to more rapid recovery of the symptomatic herniated disc, but results are not promising in compared with the conservative management. How piriformis syndrome is related with sciatica. The role of SI joint in the piriformis syndrome or deep gluteal pain syndrome. As we just saw in previous slides, that piriformis is coming from the ventral aspect of the sacrum and having a very large portion of attachment to the sacrum. Any dysfunction in the joint of SI, sacroiliac joint dysfunction, can have a direct impact over the piriformis muscle because it is the integral role, integral part of that segment. It will, when the dysfunction is occurring, the piriformis muscle has first line of muscle that is getting involved with the dysfunction. So SI is more prone to have more problem in transferring weight. So that is also one more reason of piriformis to getting involved. It is estimated that about 20% of the cases of lower back pain are actually caused by the SI joint. If SI is involved or inflamed or like having too much or too little movement, like hypermobility or hypomobility, the portion of sciatic nerve, ventral rami of the L4, L5, supragluteal lobe, or the dorsal rami of the L5, S1, S2 is generally are affected. And we can also see in the image also that this is the ventral part anterior aspect. The L4, L5 is very nearby to the SI joint. And in the posterior aspect also we can see that this nerve is just directly getting in underneath the SI joint, the sciatic nerve. Sciatica causes not always the spine related. So as we can say that sciatica is not always related with the spine. So it can, the pathology or the injury to the hip can mimic the symptoms of sciatica. So it can give pain in the groin region, in the upper thigh region, or in the buttock region. It may get worse with activity, particularly with the flexion and integrated rotation of the hip. Hip pathology we find very common in like hip arthritis, FAI, like femoroacetabular impingement. We are having a great lecture by Dr. Pooja Panda on this topic. So you can have there, you can go through that lecture. And we are also having a great lecture on the greater trochanteric bursitis by Dr. Hassan. We are having lecture in both these topics in detail that how these are getting affected and having an impact over the season.
Guys, I mean, just sorry to interrupt. And that's why we do these lectures, because I mean, these individual topics could be like one or two, 3, 4 hour presentations, because I mean, they are complex and they can also affect sciatic nerve. Over to you, Dr. Amit. Sorry for that.
So other pathologies is like osteonecrosis, like avascular nostosis. Femoral neck stress fractures can also give or have a mimicry of sciatica pain.
Of clients and even in my clinical practice.
Yes, ma'am. Pooja ma'am wanted to say something. So we move along. The systemic review and the meta-analysis of the protective factor for spontaneous regression in the lumbar disc herniation. So we can see with this research, like with this sequestration, there is involvement of 93%, exclusion is 70, which is very rare. Mostly what we find more or less cases for disc bulging and disc protrusion. So these are the two common factors we are getting more of patients with the involvement. So disc, another is like disc generation in the lumbar spine of asymptomatic young adults. So this was a great article which I found. They did a case study in the age group of 15 to 30 years of people. So they were generally having a lot of disc herniation. In the L4, L5 region, it was like 38%, followed by L5, LS1 is 30%. So we can see that doing MRI, they saw disc generation patients were having basically are asymptomatic. So we can say that this is not important, that we are finding a herniation patient in the MRI, which is relevant. They may be symptomatic, they may be asymptomatic. Generally, what we are finding nowadays, more of the patients are generally asymptomatic with disc herniation. So nearly 56% of individuals who were asymptomatic had a disc degeneration present at one or more levels. So this is a great article to know about. And this is a very recent article, as you can see, it's just 2022. This was the same, another article related with the same issues. The patients with the age like 20, 30, 30, 40, 50, 60 years age, the degeneration or the herniation of disc was increasing, but mostly the patients were asymptomatic. This is very exciting. The common symptomatic with the ages is like for disc bulge is like 40%, 50%, 60% in 30 years, 40 years, and 50 years. As you can see, these numbers are great. These patients are asymptomatic, but they are having this degeneration. There was another interesting article, surgical versus non-surgical treatment of sciatica. So there was very low to low certainty evidence that suggests that discectomy was superior to non-surgical treatment, or epidural steroidal injections are reducing leg pain and disability in people with the sciatica with the surgical indications, but the benefits decline over the time, which is very, very fascinating to know about. Sorry, sir, what is this? So discectomy might give an option to the people with sciatica pain that feels rapid relief offered by the discectomy, but for the long term of duration, the symptoms are not getting it properly resolved actually, because what we say or what we have found in the previous lectures slides, like that the dysfunction which is being present, until unless that dysfunction is being treated, the causing factors of the dysfunction, the symptoms are not going to get better. It gets worse with the ages if the dysfunction is present. This was a great article I came across. Even I can say that the same sort of findings I get from the patient in my clinic as well. The patient gets operated for a certain symptoms and certain problem, but later after the operation also the symptoms stays along as the same. There was an article, it was put up by Christopher and colleagues in 2013. The patient underwent an operative case for a L5 radiculopathy, but later they found that after the operation also the patient's symptoms was not recovered. It was getting worse and worse due to due course of time. The doctors again just analyzed the patient why she was having the symptoms along with the same. They found out that actually the peroneal nerve was getting entrapped in the knee region, that is suprafemoral region. So this was very surprising article that patient got operated, but it was not hit with the operation. So it is very important to find out clinically that why clinical examination is very important to find out the cause, that why the symptoms are there, why the irritation is there, where is the irritation, what are the causing factors for the nerve irritation. So this is very more important rather than just following the symptoms of the patient, to find out clinically more why there is such symptoms are coming from or why it is coming from.
Guys, just want to add a point here. So I think some of the points I'm going to just summarize here. The research says surgical treatments are not superior. The point Dr. Amit was trying to make was that don't treat patients by just looking at the MRI findings, because more and more research is available which says that patient may have all these disc bulges but may not have symptoms. So the idea is to clinically correlate MRI findings with patients' signs and symptoms and your clinical examination. Okay. Your clinical examination should correlate with MRI finding. This is a great example where MRI findings might have shown disc bulges, but patient is getting compression around the fibular head and neck. Okay, and patient had radiculopathy, symptoms that are mimicking L5 radiculopathy, laminectomy done, no improvement in symptoms. And that happens all the time. So the idea is clinical examination is important. Don't treat the MRIs, treat the patient. Okay, over to you, Dr. Amit. Thank you.
Okay, sir. So we have a couple of case studies. So there was a patient of 53 years old male who presented with some low back pain and left heel pain. The pain reported that he was feeling pain at the left heel during the daily routine activity. The pain was aggravated after lifting his grandson, 2 years old. He was not having any medical history, neither he was having any sort of injury. The pain on the visual analog scale was like 5, 6 out of 10. What were the findings? Like from supine to see, these are the clinical tests which we used to know, or which we used to taught in the cohorts of Gen Physio. So just try to bear with this. So supine to sit test is there. For this, the findings were like short to long on the left side, sacral base was deep on the left. Sitting flexion was positive bilaterally, but more of on the right side in compared to the left. SLR test was negative. Vandal's test was negative. So if anybody have attended the previous lectures of cohort, would like to take a shot at what could be the possible cause of the pain.
I think people who have attended our lectures before are answering. So the idea is that you have to have this level of understanding of this level of complexity to be able to treat a lot of sciatic type symptoms or sciatic like symptoms.
Because this patient already went to some doctors. The pain was just, they had some conservative management, but the pain was not going off. It was subsiding at the moment during compression or during hot bath or ice pack, but the symptoms was getting back within some hours only. So just simply, as I said, that he was having some sort of unilateral flexion issues, and along with that posterior normal dysfunction. So this is the right answer actually. So this is the second case study. The patient is 45 years old male who presented with severe back pain, unable to stand erect nor lying is comfortable, sitting worsen on the pain on the right side. Sometimes pain radiates down the heel or knee. No medical history or mechanism of injury. MRI shows mild disc bulge or disc herniation at L4, L5 and L5S1. What was the findings? Chief complaint of the patient was like low back pain, sometimes radiates down the leg. The pain was on visual analog scale like 10 out of 10. The extreme or worst case. The patient was totally restless. His sitting flexion was positive on the right. Sacral base prominent and extremely tender on the right. His ila was like deep on right, and patient was in so much pain that I could not perform the supine to sit test. So I had to perform like prone leg test, which was like long to short on the right side. So what could be the probable diagnosis about this? I'll just give you the feedback of this also. Just have the view of this video. Just a moment.
And this is a great example because if you have good understanding, you can fix this patient was suffering, was recommended surgery, right, Dr. Amit?
Yes, sir. Because first day was very, very challenging to handle this patient. He was in extreme pain and deep agony. Just try to play the video.
Hi, Tejinder from Herniated. I stay in Herniated. I had a big problem with my back pain and my leg. I could not move from my bed, and I went to the doctor for checkup, and I did MRI, and he just suggested me for the operation, but I did not do any operation, and someone just told me about Dr. Amit, and I came here, and this is my fifth session I was doing. It is almost 80% more developed than before, and I am quite well today.
So the patient was so disabled that he cannot come out of his bed. He was neither, when I just visited the patient, he was neither in a steady position in the bed again. He was just turning around. He was just like in very worse like situation. He was not, neither he was able to talk to me while sitting, neither he was able to stand properly or put weight on his right leg or the affected leg. It was in the first day was really very challenging to handle this patient. Though along with the treatment, really this is slowly this gets subsided. And on the fifth day, it was like he was getting up like 80% of relief he was having. So this is a great case. I handled it recently.
Guys, I think if you have understanding like Dr. Amit has, you'll be able to treat very complex patients easily. So that's the point of running this program, so that all of us can treat our patients better.
So there are some treatment and exercises. So these are the hand placements for the SI dysfunctions which mimics the sciatica pain. Like for the posterior innominate and outflare, we can get symptoms. So for those two conditions, we place patient in the sideline. We have one hand over the posterior superior iliac spine, PSIS, and we just grab the opposite hand and we just try to have a push to the innominate, so just to restore its normal position. And for the unilaterals, we need, so this first one is like unilateral extension. Your patient is in prone line. Just we are flexing the hip and abducting the hip, and we are having an external rotation. We are placing one hand on the sacral base, and we are just trying to open the gap in the front or anteriorly, and we just try to restore the sacrum anteriorly. And in this technique, we are just trying to, this is like unilateral sacral flexion, where we are having an internal rotation. We are just trying to having a gapping in the posterior aspect of the SI joint, so that, and just we can restore the sacral base. And I'm placing my hand over the ila, so that we can have a NP and we can restore the position of the sacrum clearly. Because I have not put up the videos, because guys, you need to be very precise to perform these techniques. So while this short lecture is very tough and challenging to learn or to get masters in these techniques, so for this techniques, we have to join the cohorts to have more detailed lectures, more detailed knowledge, and more elaboration of the techniques and the background knowledge, which is very important. There are some exercises, overway breathing exercises. We can perform with the band or without the band. Just put it around the knees. The patient is just putting it apart, having contraction for 10 counts and for 10 repetitions. We can have breathing along with the band. We can just progress this exercise with one leg lifting. We can do it on the other side as well. This is a physical exercise. Basically, this exercise is performed for the internal and external rotators of the hip, which acts as a very stabilizer of the SI and the pelvis. So here we can perform internal and external rotation. This is the bird dog exercise. Actually, this works over the core muscles of the lumbar and the pelvis, and for the stabilizers of the lumbar. So we can progress in 3 steps. As you can see, we have the flip in one hand, counting of 10 for 10 repetitions. We can do it with the leg also, counting in 10 for 10 counts. And we can do it crosses like right hand and left leg at the same time. So having more of stabilization. We can do some clamshell exercise as well, lying on the sideline. And just asking the patient to lift this paraband. You can do it halfway or the full way for the glutes muscles. Then you can have a plank exercise. We can go with half plank, because the patient with so much pain, they cannot perform plank at a time. So we can do it a half plank initially. As the symptoms progresses, we can go for a full plank.